by watching a video first. And it's just going to give you the normal baseline pediatric stuff. And then we're going to go into some anatomy and physiology differences. And then we're going to go into how to assess a pediatric patient, and then how to treat all of the pediatric specialties. All right, so we'll start with the video.
Hey squad, welcome back to the channel. My name is Mike, and on today's episode, we review pediatric vital signs. What are those correct ranges for specific age groups of children? The American Heart Association's Pediatric Advanced Life Support Program provides guidance on what normal vitals are for kids depending on their age. Before we continue, be sure to answer that question of the day in the comments below. How many babies have you personally delivered in the pre-hospital setting? Now let's jump over onto the computer and check out the guidelines for these pediatric vital signs. All right, squad, now that we've moved over to the computer, let's break down the vital sign, the normal vital signs for these particular age ranges. And like I said, everything is based on a mean average in years for these specific age groups. So we have neonate, birth to 1 month, infant, 1 month to 1 year, toddlers are 1 year to 3 years, preschoolers are 3 years to 6 years, school age children are 6 years to 12 years, and then adolescents are 12 years to 18 years. So yes, typically you would think adolescents 12 to 18 years, teenagers, adolescents, but some pediatricians actually go not just by the years of adolescence, but they treat them via the signs of puberty. Okay, and that pretty much means that when they start seeing signs of puberty development, breast development, deeper voice in boys, signs like that, they actually start treating these children as adults, so adult doses and medications and such like that. So depending on your area, you guys might treat in years. Everyone is a child until they're 18 years old and they get treated under pediatric protocols, or sometimes the doctors in the medical direction give you leeway and say if there are signs, visible signs of puberty, then give them the adult doses or call med control for a discussion. So just remember, everything is broken down due to age. All right, so let's start moving into our columns here. We're going to start with respiratory rate, and the neonate and the infant, according to PALS, have actually the same respiratory rate, and that is 30 to 53 or 60, depending on which text you read. The new PALS that came out in 2016 actually has the 30 to 53, but you'll also see some studies and publications with the 60 breaths per minute. All right, moving right along to the toddler, we have a range of 22 to 37 breaths per minute, preschoolers 20 to 28. And what you guys will start to see is as these children are growing, our vital signs begin to normalize. So by the time that they are adolescents, they pretty much have the normal adult range for blood pressure and heart rate and respiratory rate and so on. So for school age, these are where my children are. You have 18 to 25. And then finally, like I said, they begin to normalize, and you see that normal 12 to 20 breaths per minute. And this correlates with the adult vital signs. Okay, so moving on to heart rate. In the neonates, you will see the highest heart rate. Now, PALS actually breaks it down to awake and asleep. So we will do that as well. The awake heart rate is anywhere from 100 to 205 beats per minute. And the asleep is 90 to 160 beats per minute. In your infant, you're looking at 100 to 180 for awake and 90 to 160 for asleep. For your toddlers, you're going to be 96 to 140 for awake and 80 to 120 while they're sleeping. For the preschoolers, again, we start to see that normalization, right? 80 to 120, not as normal as you'd like, but we're getting there. 65 to 100 beats per minute for their asleep rate. School age, 75 to 118. And then for their asleep rate, 58 to 90. Okay, and then finally, when things start to normalize, you see that normal 60 to 100 while they're awake, and then that 50 to 90 beats per minute while they're asleep. So everything is starting to normalize here. Remember, these are the adult rates that you would see for a 26-year-old, or the normal rate you'd see for a 45-year-old. Okay, so moving on to blood pressure, I broke it down into systolic and diastolic numbers because they do have some ranges, but we're going to start off with that neonate. Okay, so you're going to start to see very low blood pressures for these infants and neonates, and then the blood pressure progressively increases as time goes on and these kids get older. So we're going to start with the neonate. You're going to see a systolic blood pressure of 67 to 84 and a diastolic pressure of 35 to 53. Okay. Then moving on to the infant, you're going to see 72 to 104 systolic and
Hello.
a diastolic
Hello.
of 37 to 56.
Can you not hear the video anymore?
For the toddlers, you're going to see an increase again in 86 to 106 and a diastolic of 42 to 63. Now, remember, guys, these numbers are really odd.
Hello.
Hello.
Yay. All right, so I just pulled my internet cable out of my computer because Monday I found on the Wi-Fi we had no problems. And again, we're going to see if this is coincidental or if it actually works or not. All right, so where were we on the video? What was the last part you guys heard?
We last heard the diastolic being 35 to 53 for neonates.
35 to 53. Okay, so you missed both infants and toddlers. All right, let's go back to here.
Of 35 to 53. Okay. Then moving on to the infant, you're going to see 72 to 104 systolic and a diastolic of 37 to 56. For the toddlers, you're going to see an increase again in 86 to 106 and a diastolic of 42 to 63. Now, remember, guys, these numbers are really odd, but they're law of averages based on the studies that the American Heart Association did. And remember, these numbers are directly out of PALS algorithms. So, I'm not just pulling these numbers out of thin air here. So for the preschool child, remember the 3 to 5-year-olds, you're going to see 89 to 112 systolic and a diastolic of 46 to 72. For the school aged, again, both my children are in this category. You're going to start to see 97 to 115. Remember, we're now starting to get into normal ranges for adults. 57 to 76 for a diastolic. And then lastly, the adolescents. Remember, this is where we want to shoot for as we're an adult, is that normal 110 to 130, that nice round number of 120, as everybody says, and then 64 to 83 being that number where we get 120 over 80 for the adults. Okay, so as we start to get older, our blood pressure, our heart rate, and our respiratory rate all start to either increase or decrease. With the respiratory rate and heart rate, they decrease. With the blood pressure, we increase it. And we finally get down to our adult vital signs down here, which are the ones that you guys should see and go, hey, I recognize that. That's it for today's video, guys. Thank you for watching, and I will see you guys in the next video.
All right, so did everybody copy all that stuff down?
I did.
You did? Okay, good. No. So basically, we're just going to give you a little bit of a refresher from lifespan development, right? Because we talked about most of that during that class, that chapter.
Can I ask a quick question?
Sure.
I remember in one of the labs, we were told that the blood pressure will never be an odd number. It will always be in multiples of 2, but what I wrote down here, we got like 131, 83.
Right. So those are all like median averages of numbers. So like if you have over an 82 and an 84 and you average them out, that's 83.
Mm-hmm.
Right. So go higher or lower if you want on the right. When you're manually auscultating a blood pressure, you should never get an odd number, right? But if you're using a machine, the machines will get odd numbers. Okay, so give or take, it should be in that range. It's not going to be exactly right there, right? But it should give you a heads up. Okay.
Okay.
As into what like a normal range of blood pressure should be. So that when you get there and you see the kid and you take a blood pressure and it's like 70 over 40, you don't freak out because that's normal for that age group.
Okay.
Okay. And here's another way. Well, did the book give you guys a formula at all? Does anybody remember a formula in the book for systolic blood pressure?
The formula, like the mathematic formula that you gave us in the beginning.
I don't know. Did I give you one in the beginning?
I recall one. Yeah, I recall a math one.
Okay. What did I give
It's
you?
in
the
my other
beginning?
book though. I have to like go get my other notebook. I can't remember it off the top of my head, but I know what you're talking about.
Don't worry about that. So in worst case scenario, you don't remember any of that. All right. If you want to know if the systolic blood pressure is within range for that child, okay, what you're going to do is you're going to take 70 plus 2 times the age of the child. All right. And that will equal your systolic blood pressure. Yeah, welcome back, me. All right. Everybody hear me again?
Yeah.
Hopefully that'll be the last hiccup. we know it won't be, but we'll try. All right, so the formula that I wrote again up on the board, because I have a feeling you didn't see it, and I can't find my cursor. Where is it? There it is. Is another way just to come up with a quick estimate, right? If you can't remember those ranges. All right, so if you have a 4-year-old, okay, 2 times their age, 8, 78 should be their systolic blood pressure, or somewhere within that range. All right. Otherwise, we're going to talk. What? Any questions? Questions? Heard questions?
Oh, yeah. So this is only for the systolic. Is there a way to figure out the dystolic?
No, we don't really have one for the diastolic. Okay, so, and a lot of times we don't, it's really hard to hear the diastolic in children. Most times you're only going to get the top number if they even let you sit there long enough and squeeze their arm for it. Okay. It hurts. They don't like it. They pull away, especially in babies. You know, smaller kids really don't understand very well what's happening. So you can
Okay,
try.
just wondering.
I mean, there's no, but yeah, no, there's no actual like formula for the diastolic. Not that I've found. If you find one, let me know. Right, let me see. Nope. Nope. Blood pressure is mostly all we worried about is systolic in children. It's not really too much the diastolic one. What you're trying to do is maintain a median average pressure or MAP of 65, but I'm not gonna, you guys don't need to know all that math. That's not something you have to worry about. So what we will worry about though, unfortunately, is the anatomy a little bit of the children. So the first difference we have is the airway, obviously. The airway is much shorter, much more compact. It sits a lot higher up in the child's chest. Okay, so, and they don't open up the same way. They don't have that flexion in the neck, all right, because the head, so the angle between the shoulders and the neck are a little bit different. So we don't necessarily pad their neck when we go to pad stuff, we pad their shoulders instead to try to make that airway line up properly like we would an adult, where we would like flex the neck a little bit. Like in children, we have to pad their shoulders and flex them there. Okay, so the epiglottis is also a little bit higher and it's more towards the front, which is again why epiglottitis is a problem, because then it just covers the airway completely, right? It makes it very hard to breathe. All right, so again, the neck is a little bit longer, but it's still proportional to the body. Their tongues are much larger than the airway, than the opening, all right, from the mouth. So when you clear the tongue, you got to make sure you actually get in there and use the appropriate sized airway to keep the tongue out of the airway itself. Like when you go to use an oral airway, a lot of times that simple maneuver, or just like repositioning the head to reposition the tongue, will open the airway up pretty well. So the airway is a lot smaller and thinner. They say it's the same as a drinking straw. I don't know. We have tubes that are bigger than drinking straws that we put down child's airways. So I don't know if I believe that so much, but they're a lot smaller. But they can be easily obstructed, right? So we got to worry about suctioning. We got to worry about where they're breathing from. Okay, are they actually nose breathing? Are they belly breathing? Are they mouth breathing? Right, and then what is that respiratory rate? Is it within those normal limits that we gave you? Okay, and then children require twice the amount of oxygen. All right, which is why most times, most problems in children before they get out of hand can be solved with oxygen. Right, most cardiac events, most altered mental status events, most of that stuff is all from a hypoxic event or started from a respiratory event. Okay, a lot of that stuff we can fix with either opening the airway, increasing the airway, or just giving them some supplemental oxygen for whatever reason. All right. And then the diaphragm. Okay, their muscles aren't quite fully developed. All right, and then any pressure on their abdomen, right, because they're using that belly, they're using every muscle in their belly because the diaphragm hasn't fully developed in order to just breathe on its own. Right, so then basically by cutting off or putting any pressure on their abdomen, right, we're causing more respiratory problems than we're solving. All right, so when you're putting on any type of devices, seat belts, any of that stuff, like we're not tightening it around the stomach. Okay, that's why you're supposed to be able to get at least like a finger in between the car seat and the belt buckle when you put them in their harnesses, right? Because you want them to be able to breathe. You want that little bit of space for them to be able to motion, but you don't want it so loose that they slide out of it in the, if something happens. So oh yeah. Sorry. Because their chest, there's less meat there, there's less stuff. Everything is a lot easier to hear. You'll hear the heart tones a lot better. You'll hear breath sounds a lot better. The only problem with that is that you're not going to be able to notice if they're having a problem breathing so much, because you'll still be able to hear the breath sounds. So you'll hear them and you won't know if that's like a decreased or an absent breath sound, or it's supposed to be, what would be a decreased breath sound in an adult, right? In a child, they still sound good. So we just have to be careful. Watch the O2 saturations, watch the color of your patient's skin, do the cap refill test to see how much air is actually being perfused and stuff like that. All right, so now we get in the circulatory system, and basically the most significant difference is that their hearts beat a lot faster than ours. They're constantly tachycardic until they hit teenage years, basically. So if you go in and you see an infant and their heart rate's like 180, like that's okay, that's normal, right? So, but like I said earlier, basically what you're looking for are the pallor, right? The color of the skin. Do you feel the pulses, right? What's the cap refill? What's that perfusion looking like? Are they warm? Are they cold? What's the temperature? Right? Because all those blood vessels and all that stuff is real close to the surface of the skin. So that's why babies are nice and warm. All right, this is just the pulse rates. We gave those to you already though, so we're not gonna worry about that. The nervous system, a little bit. Okay, so the head to body ratio is larger in children, right? Their head is bigger than their body sometimes, which is why they're a little off balance, we'll say. Okay, the back of the head is bigger than everything. All right, but that subarachnoid space that we talked about for us, like that cushion in the brain, right? There's less of that. So that's why like any type of injury, they always say, cradle the baby's head, be careful of the baby's head. It's not because they're soft, right? In the beginning they are, but as they get older, it's still not because they're soft, right? Once those suture lines all heal up and form the different plates of the skull, right? It's got its protection. It just doesn't have enough cushion inside. All right, so we still have to be careful. All right, and then even just playing with them, right? You got to be careful because of that shearing force, like shaken baby syndrome. Everybody's heard of that, right? Basically, the brain and the cerebral vasculature tear away from the inside of the skull because there's nothing there to hold it and keep it in place. Right, so we got to be careful of those like shearing type forces. All right. So we talked about this, right? The pediatric brain, or how they requires more oxygen. Okay, so there's a higher blood flow, higher oxygen, higher glucose. All right, so that's what we're really worried about in pediatrics is perfusion, O2, and their sugar levels, right? Okay, spinal cords, we don't really get injured too much because we all know, we all make fun of it, but I usually say bumbles bounce. And you drop a kid, they usually bounce and they're fine. Okay, the muscles haven't had a chance to become rigid yet. They don't really understand the whole like brace yourself for your fall thing, so they're still kind of limp. That's why most people who are intoxicated walk away from car accidents, right? Because they don't brace up for the impact. They have no idea what's happening and they're just kind of loosey-goosey. All right, well, that loosey-goosey keeps you alive. Right, when you brace for something, when you see it coming and you brace for it, you're actually doing yourself more of a disservice. You're going to injure yourself worse than if you just let it happen. Okay, so that's kind of why kids are pretty good like that. So the GI, right, their abdominal muscles are less developed. All right, there's less protection. All right, there's less fat. There's, less meat. Okay, so the liver, spleen, kidneys, they're all larger. They're all more up close. They're all right up, like bunched up against the skin. Okay, so that's why we got to be more careful, right? Everything can bleed, be injured. It takes less of an injury in that area to rupture something for a child than it would an adult. Okay, and because everything is still closer together, right? One injury might have multiple organs involved. So just be careful of that, especially in trauma situations. Okay, when we talk about the growth plates, right, we talk about where the bones are growing, where they're stretching. All right, so that's what makes them softer, more flexible. Okay, but they are more susceptible to that green stick fracture that Mark talked about when we did orthostatics, right? Or orthopedics, sorry. And then unfortunately, things may not grow at the same time. Things may grow too fast. All right, so you can have bone length discrepancies both with an injury, okay, or one side grows faster than the other. For whatever reason, one side stunted growth happens. My brother had to wear leg braces like from 10 to 13 because he grew too fast and like his bones were too weak or something. The doctor was saying, I didn't really understand it at the time, but apparently he grew too fast and they had to wait for everything to heal before he they would let him do stuff again. And it was pretty painful for him. It was weird. So again, the same with any adult, right? We're going to mobilize everything same way we would for adults. Okay. Again, we talked about this, right? The fontanelles in the front and the back of the head. Okay. Again, those suture lines will close. Okay. So until they close and you have those fontanelles, right? And they're still in place. When we talk about pediatric assessment, we're going to talk about how we're going to assess those fontanelles in order to help us determine what's going on. Because we can be able to see right into things that we can't usually see. Like if they have a sunken fontanelle, that means they're usually dehydrated or something else happened, right? But we'll talk about that. All right, and then your rib cage. Your rib cage is highly elastic and pliable. All right, all that cartilage hasn't really settled in, hasn't really gotten hard, and there's not many, injuries to it. So, and again, there's not all of that muscle on top. Okay, so everything is basically right. I don't want to say subdural, but everything's real close under the skin. Okay, there's not a lot of protection. Doesn't mean we put our kids in a bubble, but right, they tend to get hurt. So the skin obviously is thinner, right? There's less fat, there's less muscle. The only time we worry about this is in burns, okay, because the burn doesn't have to go through as many layers, all right, to do as much damage. Okay, this is why, when they pull the pot down on themselves, it's horrible. Okay, so again, because they have more body surface area than mass, right? They have more skin than they have like weight or an area to them, right? We did the rule of nines, okay? So they lose fluid faster and they lose heat faster, right? There's more surface area to lose that from than to hold it in. All right, let's take 5 minutes because I think somebody has to go outside here and she's not listening to anything I tell her to do. So I'm gonna let the little rugrat out here for a minute, and then we're gonna do some group assessment things. All right, so let's take 5 minutes and we'll come right back. All right, let's see. Emily, walk me through a scene size up. What are we, and remember Mrs. Klein, so what are we looking for? But let's do it for a kid. So as you're walking up, we're not gonna do a scenario now. We'll do them when we get to the other parts. But let's you create a scenario from your scene size up and we'll build one. So let's go.
Like, so you want me to create what's going on, or?
Sure. You do a scene size up, and then
Okay.
whatever your scene size up is, the next person will build off of.
Okay, so I enter Klein with my PPE, and the look through the scene, everything seems safe. I see a maybe 3-year-old kid who's lying down on the ground, says looks in pain.
Okay.
Yeah. I might consider C-spine.
Okay. So you got the age and the gender. Where did you find them?
On the
On the
near the
floor.
entrance, on the floor.
Near the entrance. Okay. And are you going with an NOI, an MOI? What are you going with? Is there a visible reason for the pain? No. Am I gone? It's me, right?
No, I can hear you.
Oh, did she disconnect? Oh, it was her. See, she got me all nervous, making me think I disconnected.
Sorry.
That's okay.
I guess we got called, and just by not the child's parents, person working at Klein saying that
We'll call it a babysitter. Let's say we got called by a babysitter.
someone got called by a babysitter and
Okay.
said that
they actually they don't really know what happened. They turned around 1 second to get something, and they walked right back. And
The good old don't know what happened story. I like it. Okay. So we got a 3-year-old in pain, don't know what happens. All right. So what's the environment look like?
pretty busy. It's like late breakfast, and
Are we talking about like illegal daycare here, or like what are we talking about? Pretty busy.
Yeah, pretty busy.
So late breakfast, one kid, babysitter. What's busy about it?
There are just a lot of students just walking back and forth, people carrying plates back and forth.
So are we in a school now? Where are we at? Now there's students carrying plates in
Well,
the
not
cafeteria.
students, like people who like work there.
Okay, so we're going to be in a daycare then. We're going to call this a daycare.
Okay.
Okay. All right, so we got a busy scenario. No one saw what happened, as usual. 400 people. No one knows anything. All right. Carolina, run us through the first half of the assessment. What's your
Okay.
general impression? Okay, and this is where it's going to differ a little bit. So I put it up here for you. Okay, this is your bread and butter pediatric assessment tool, right? It's the pediatric triangle. You're gonna look at the appearance, the work of breathing, and the circulation to the skin. All right, you don't have to touch them. You don't have to do anything. It's your basic first visual glance. All right.
Okay, so she said this child is on the floor.
Right.
So
She said in
he-
pain.
Yeah, so he's probably crying,
Okay.
breathing fast,
Okay.
labor, right?
I
Kind of.
mean, I'll go with whatever. We can go with this. This is
Okay,
getting good.
because he's crying in pain. Okay, probably freaking out.
Crying, labored breathing.
Seems a little flushed because he's been crying.
Okay.
And like you said I don't have to touch him. Okay, so I'm not doing that.
Well, not yet. This is just your general impression.
Okay.
So do you have a general impression yet?
Yeah, so child on the floor, crying, fast breathing, a little red looking,
Okay.
circulation to skin. Honey, I'm doing schoolwork. Thank you.
Well, you did say flushed. So that's circulation to skin, right? There is,
Okay.
he's not pale. Okay. So there's circulation going on.
Mhm.
All right. So we talked about that. So let's go further into the appearance. He's crying, right? So that makes him what?
He's alert.
Okay.
I asked him what happened. He says tummy hurts.
Okay. So he's alert
He's verbal.
and he's verbal.
Mm-hmm.
And now we're going into a tummy.
Yeah.
Okay.
I don't remember what the P is. Is it pain?
Mm-hmm.
Right? It's pain, right? Yeah.
Yeah, but I mean, if he's alert, he's talking to you, right?
Yeah.
Okay. So he's interacting. That's always good. Right. There's some muscle tone there. Okay. So he maintained good eye contact, right?
Yeah.
And then we have this little tickles thing. Okay. That we can determine whether how sick or not sick they are. Okay. Based on their general muscle tone, how willing they are to be interactive with you, whether we can console them or not. Right. Will they look at you? Do they look away? Or are they not looking anywhere? Right. Whether they're talking, crying, can they interact with you? Okay. So all that stuff was a good appearance part of the pediatric triangle, right?
Yeah.
Okay. So then we're gonna go to the next part, and we're gonna have Addie do the next part.
Oh, okay. Let me
Right. So
Wait, so we're done with the pediatric triangle?
Nope, we're done with the appearance part of the pediatric triangle. Now we're gonna go into the work of breathing part.
Okay, so I believe we said before that the child was like breathing pretty fast.
Mm-hmm. Right,
And
now we're gonna describe it though.
describe it.
Right, so we know that breathing increases, right? Because,
It's trying to like compensate and
right. So
get off.
now, which way, how would you like him to be compensating? What are we compensating for?
What do you mean?
Is he just labored? Are there retractions?
I
Is
mean,
there
if
nasal
like-
flaring? Is he sitting in a certain position? Do you hear
He's probably
stridor?
sitting
Do you
like-
hear?
he's probably, if his like stomach's hurting, he's probably sitting in like a tripod or like knees to like the chest sort of position, most
Okay.
likely. If it's just like a stomach ache and there's no like actual problems with breathing except that it's just rapid, I wouldn't like assume there would be like any abnormal like airway noise or anything like that.
Okay, so we're not going with any airway noise or anything.
Mm-mm.
So we're just gonna have him sitting almost in the fetal position. Is that what you want to call it?
Yeah.
All right, that sounds good. All right, so now circulation of the skin, right? So we talked about it, he's flushed. Okay. Which is fine. But just know that, the other parts, okay? There's pallor, there's modeling, there's cyanosis. All right, and all, from compensated down to decompensated shock. All right, so let's keep going. So where are we at? From all of the assessment triangle findings, Addie, where are we at right now? Is he unstable or is he stable? Are we going to treat life threats and transport, or are we gonna do a little bit more assessing and like sleuthing around the scene a little bit?
I do a little more assessing because at this point there's like good circulation. The breathing just seems to be rapid because of like stress.
Could be, yeah. We're not sure yet.
So
So we're gonna call him stable, right? Addie says he's
Yeah.
stable.
Mhm.
Okay, everybody else agree with stable? Does anybody disagree with stable? No, we're good. Okay. Let's do our hands-on. And let's have, who wants to start the hands-on? Let's have Bridget. Go ahead.
I'm sorry, can you repeat that, Dustin?
So you're gonna start your hands-on assessment now, right? We've done our assessment triangle. All right,
Okay,
now we're
great.
gonna get deep in and we're gonna see what's going on, right?
Mm-hmm.
So do we see any life threats? Is he bleeding? Is he bleeding out, right? Exsanguination is bleeding out. Is he bleeding out anywhere?
I would really hope not.
Right, well, so far he's not, so it's up to you. Right, everyone else has laid the groundwork. You're gonna continue it, so.
Okay, so he's not bleeding.
Okay, who's not bleeding? That's great.
Mm-hmm.
All right, his airway. Maddie said there's no airway noise, so there's no audible stuff. Right, so his airway is what?
Open,
Okay,
patent.
yeah. His breathing,
I-
we talked about, right? His breathing was a little bit labored.
Mm-hmm.
Okay, but it's nothing out of control right now, according to them. Okay, so breathing is what?
Faster.
No, breathing's good. We'll just call it good, right? We don't have to worry about it, right?
Okay.
We're not treating anything breathing yet.
Should we have to worry because he's crying that would do anything to obstruct his airway?
I mean, yeah, he can aspirate, sure, on crying, but like I mean, babies cry all the time, so you can keep an eye on it, but I wouldn't like hover over it and be like, wait for it to happen kind of, you know what I mean?
Okay.
Circulation, they said he was flushed.
Mhm.
So how else can we assess circulation?
We could check for a pulse. If
Okay.
he would let us, we could do a blood pressure, but I don't know if that'd be the best idea.
Well, we're just doing life threats right now, so let's do his pulse. What do you want his pulse to be? He's 3 years old.
Okay, so it's probably faster than I would be used to.
Okay, but you have the ranges. So what do you want us supposed to be?
102.
102. Okay. Is there any disability? Are we dealing with a specially challenged patient? A special needs
No.
patient?
No, just a 3-year-old on the floor.
Okay. And was there any exposure to anything? We're dealing with a hazmat situation.
I'm going to give Klein the benefit of a doubt.
We're gonna give clients the benefit of the doubt and her illegal daycare at 70 years old. Okay,
Mhm.
sounds good. Okay. So you said the airway was open and it's gonna remain open. Okay, so let's talk respiratory adequacy. Right? What is the respiratory adequacy of this patient? They have some labored breathing, right? But we got to figure out why. Anybody?
I would be worried how long they had been crying. And it was
Okay, we can try to figure out how long it happened, right?
Right,
Let's
I
just
mean,
talk about. Go ahead.
if they've been crying for 20 minutes uncontrollably, I'd be
Right.
worried about not hypoxia, but definitely not, getting enough air in for,
Okay.
adequate respirations.
All right, but let's talk about how would we assess respiratory adequacy in someone who has labored breathing. Right, we're doing our assessment. We're making it up as we go. So how are we going to assess their adequacy of breathing? We said it was labored, but now how do we tell how labored is? What do you guys want to do?
Listen to lung sounds, right?
Okay, so who was that?
We do.
Who said lung sounds?
Gianna.
All right, so give me some lung sounds. There's no airway noise.
Okay.
There's no audible airway noise, right? So there's no wheezing and no stridor, unless we
Okay.
have a change. But from the beginning, so far there has been no wheezing and no stridor. Okay, so what else you want to do?
The child said that his
gonna
stomach
assess the
hurt though, right?
lungs. He did.
Okay. So
Or
it
they did. We
probably is
never really said
labored
he
from
or he.
pain. Or
It could be.
like,
Okay, but
yeah.
you said lung sounds, so let's talk lung sounds.
yeah.
What
Well, yeah, let's say we have clear lung sounds.
so you want to go clear? Okay.
Yeah.
What else we want to do?
Check for adequate chest rise and fall.
Okay. Right. We know they're labored breathing, but if the lung sounds are clear,
Both sides too, like bilateral
sides.
chest rise and fall is
Yep.
what I meant. Okay.
Have
What
we
else you wanna
checked
do?
yet? Sorry, have we checked like just asking them to like open their mouth and checking to see if there's anything in there?
no one's done that yet. No,
They talk to us though, right?
they did talk to us.
They still want to check just to make
You
sure.
still want, okay. So there's not. Well, I don't know. You decide. Is there anything in there? You checked.
No.
No. Okay. Good. All right. So we don't have an obstruction. But what else can we do for respiratory adequacy?
Oh, we should check his SpO2.
There we go. Let's
know
check
with
his
babies,
SpO2.
You don't put a pulse ox on the, like when I did my ride time, our last call was an infant
Yeah.
and they put this like little piece of tape on his toe.
Yeah.
I'm not sure. I think that's what you do here, right? They said he was 3 though, right? So he was a little older than that baby.
He is 3. Yeah. So we could probably get the pediatric pulse ox on.
Okay.
If not, what's the other way we can check?
Can you check for capillary refill?
You sure can. And what are we looking for?
Refreshing within within 2 seconds or something like that. 1 second.
Right.
Yeah.
Less than 2 seconds. Okay. I'm just asking. Okay. So
It's the same for kids, right? As adults, that at least, because I know like a lot of their other vitals are different.
Yeah, cap refill is mostly the same for everybody. It should
Okay.
be within that less than 2 seconds. Okay, so SpO2, what do you want to do? He's
Gonna
big enough.
check
He's a
it.
3-year-old. Yeah. Well, give me a number.
Okay,
We're doing
let's
this
say
up as we go along.
we have 98.99.
Okay, 98.99. So, and what was his cap refill, Mr. Joe? You
Less
said
than
it
2
was less than
seconds.
2. Okay. So it's not a respiratory problem, right?
Nope, not looking like it.
Okay. So we're doing all that. We maintain the airway. All right. We just talked about all of that, right? So determine if they have a pulse, bleeding, shock. We did that. In infants, yes. In infants, palpate the brachial or the femoral pulse. All right. We don't do radial pulses. All right. So either in their elbow, you'll find one, or you can do the femoral pulse. Okay. Most children try to do a carotid. All right. We want central pulses on children.
Cool. All right.
Skin temperature and moisture, we talked about cap refill time. All right, who's next? Emma, what else you want to do other than check the throat?
Is it, you said other than checking the throat?
Well, you were the first one that said let's look inside the mouth, right? So other than looking inside the mouth, what else do you want to do?
In relation to like
Well,
primary
here we
assessment,
are.
like
Well, we're still trying to
ABCs?
figure out. We kind of just ruled out respiratory, right? Because
Okay,
the clear lung sounds, SpO2 is 98, cap refills less than 2. Okay, so this isn't really a breathing problem. So
okay.
now we still have to figure out why there's a 3-year-old that looks like they're in pain and now they're crying on the ground. Right. So what else do you want to do?
I mean, it's not up here, but if it's with their stomach and they would let me touch them, like I would want to kind of, I would want to like palpate their stomach like really lightly, but that's not what's up here. So I don't know if that's what I would do next.
Well, I mean, we can, right? I mean, this one is, we know they're alert, right? So we've already done the AFU scale.
Yeah.
Okay, we can check their pupillary response, but that's something you can look at. But okay, but they're in pain, right? So the next 3 kind of fit,
Yeah.
right?
I mean,
So
yeah,
are they
I would
injured
basically,
or is it tummy? Like they pointed to their tummy, but are they sick or did they get hit in the tummy? Like, right? So what do we? So what do you want to do? So you said you want to palpate. I'm okay with that. We can palpate at this point.
yeah, like after
Right.
checking to make sure it's not anything like external.
Okay, so you want to check for externals? Do you find anything?
No.
No, so there's no bruising, no nothing like that, no red marks.
Mhm.
Everything looks good. Okay. So
But there is
then,
rigidity and distension in the lower abdomen.
oh, you want there to be distension in the lower abdomen already?
Well, rigidity.
Oh, so when she palpated, she found rigidity in the lower abdomen. Okay.
Sure, we could do that.
Well, you did say you wanted to palpate. Apparently you found something.
Okay.
I mean, we do have to find something. The kid's obviously crying in pain. Something's got to happen.
Yeah, maybe his stomach is like a little like the lower abdomen is tender or a little bit rigid.
Okay. So now what are we gonna do? Right. So we've done our assessments. Okay. We have lower abdominal rigidity. So now what could that possibly be in an infant or in a 3-year-old? Did you say right
Like, could have
side, left
swallowed
side? Did you pick
something
a
they weren't
side?
supposed to.
No, just lower.
Just lower. Okay. So we're not going to go with appendicitis. We're just going to pick. You're just
Okay.
going to make this super hard and not pick a side. It's just lower.
It could be that he hasn't had a bowel movement or constipated or something. I don't know.
I mean, it could be. Does that usually happen in kids?
No.
Could.
It could. I mean,
I've
You know,
seen it happen.
I could fall out the
could,
window over
but-
there, but.
Not
Okay.
every kid loves pooping.
That is true. All right. I'm just saying, I've not seen pediatric bowel obstructions.
It's generally not like a medical problem. It's
Very
something
often.
that passes in time.
Well, what,
So there-
how long was he crying for? Did we get to that? Because if he's just crying for a while nonstop and complaining of abdominal pain and hasn't gone, like if he hasn't pooped in a while, like a good couple days, then I'd be worried.
I'm sorry, I missed the age of the patient in this one.
We're talking about 3.
3. There is a psychological phenomenon around that age in which a child is scared to poop because they believe it is a part of themselves.
Of course you would know that, wouldn't you?
Only he would.
Wow, this has gotten deep real quick.
All right. Let's go with the psychological condition of I haven't pooped in a week. Okay,
Alrighty.
this is not where I thought this was gonna go, but this is
Hey, man.
good. We're learning things. Do we know the name of the psychological condition?
It's been a while since I've heard about it, but I can try and find it.
Okay. All right, so we found some rigidity in the abdomen. We don't know how long they've been crying because Mrs. Klein is old and she's senile and she likes to leave her husband on the floor for hours.
Wow.
So the kid's probably been there for a while too. We'll go with that.
That's awful.
Well, I
We
did
should
say
do a
Mrs.
welfare check on him while we're here.
I did
Yeah.
say Mrs. Klein was running an illegal daycare at this point.
I
but-
hope you don't have any kids.
Maybe he was hit in the abdomen with a frying pan.
Yeah, well, maybe he got
I'm gonna
whacked with
throw
the frying
hands with
pan. I
whoever
got
did
that.
that.
We haven't ruled that out yet.
We haven't ruled that out yet. No.
I mean, it might be early for bruising and ecchymosis.
Well, did we ask the kid? Hey, yo, what happened?
She did. Someone did, and they said tummy.
It
Yeah,
is
and
So,
he
simply
like,
might-
what
called-
happened before?
Hold on,
the
hold on.
scene
Phil's gonna give
happened?
us the name of the thing.
It is simply called poop anxiety or
Poop
functional
anxiety.
constipation.
Awesome. Poop anxiety or functional constipation.
Knowing Mrs. Klein, he's probably afraid of, like narking on her.
Right. Okay, so.
Another thing to keep in mind with little children is that when anything hurts, they're always gonna say is their tummy, even if it's another body part.
That is true. Everything seems to be their tummy. It's all referred. However, we'll,
Well, we can ask, does it hurt anywhere else?
we'll
And head
continue with
down.
this train wreck. That keeps getting worse. All right, so now we have we have rigidity in the lower abdomen. Has this now become stable or more unstable? I mean, I guess they're still stable, but
Now
Has it
they start
become-
seizing out of nowhere.
Did we check for temperature at all?
no, we didn't, and his skin was flushed. And if he just
Okay.
started having seizures, that would make sense.
Oh yeah, because it's more likely for children who have high fevers to
Seizures.
seize. Yeah.
Mm-hmm. Okay, well, now he's seizing. Now what are we doing?
All right. Well, we're not gonna hold him still because that could hurt him, right? We're just gonna turn him onto his side and let him seize.
Okay. It was a quick seize, it's about 10 seconds.
All right.
Now what do you want
quick
to do?
seize. Now I want to check his. Well, first, I guess I'm gonna check his level of consciousness. Make sure he
Okay.
didn't injure himself in the process.
Yeah.
Make sure he's breathing. Then I want to check his temperature.
Well, that just happened.
Yep.
That just happened. We'll say this happened. Okay, now, I mean, how many more of these circles do I have to before we get to this?
Let's transport.
I'm gonna
could do
prepare
like
for
3
rapid
more.
transport. since the
Okay,
charge
that's
is
a good
so-
idea. Awesome.
Yeah.
Okay. Cool. Not that you guys were wrong, but like at some point,
But that did come on like out of the blue towards the end. So we were doing
There was-
well and started seizing.
were you? There was pain. Okay,
Were
a,
you-
a potentially serious anatomic injury or anatomic abnormality. We can even go with this one because there's not supposed to be lower abdominal rigidity, right? There's an abnormality noted. We don't really have any history, and we don't have that one. So before the seizure happened, you still had 3 check marks here. Granted, they all kind of happened at the very end because you guys just started piling on this poor kid, which leads me into my next point. You guys actually understood something without understanding it, but so
I was gonna wait to do history or sample or anything like that till we got to secondary, because that's what the sheet does, right?
yeah, kind of, but I mean, we're going faster. So if you want to do this with, we'll do this with compensation. I wish I had a touch screen and didn't have to try to do this with my mouse.
I love that handwriting.
Thank you. It's wonderful, isn't it?
Did you say with your mouth or with the mouse?
Yes,
definitely,
it's
His
definitely with
mouth,
my mouth.
obviously.
Obviously, with my mouth.
He's just licking the pad.
That's right. Just look in the pad. What the hell is this one over here? Compensation and we'll do this one like AVPU. All right. So basically, children, and you guys kind of just showed this without really realizing that you showed this. All right. Children compensate during their levels of sickness better than we do until they stop. All right. So, like an adult, we'll do adult in green. All right. An adult, like they kind of have the compensation curve. And I guess AVPU really isn't the right thing unless you start with the A down here. That's really not right. But you kind of get what I mean, right? Like they'll compensate and they plateau, then they decompensate, right?
Right, but a
So-
child starts out
Let's make this
higher
one,
and-
let's make this one time. And make this one comp.
Okay.
All right, that'll make more sense.
But they can drop precipitously.
If by precipitously you mean off a cliff, yes.
Yeah.
So
Like-
children start up here
Freaking out of nowhere.
and like they're doing good, and then all of a sudden it's like a cliff. It just goes worse, 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 and they're dead.
Dead.
Okay. So my goal is that you meet the children anywhere from here to here. Okay, because if you meet them here, it's like a roller coaster. You're about to go on the roller coaster ride. All right, nobody wants that. Okay, but again, it's almost impossible for us to know where they're at in that little range. Okay, because that range, they will compensate so well until they can't compensate anymore. Yes, Mr. Phil. No.
Oh, I didn't think I said anything.
Well, you were unmuted, so I thought you were waiting for me to stop so you could say something.
Oh, no, I just forgot to mute myself again.
That's fine. I just usually you wait or you unmute and then you say something. All right. So is everybody good with this? Everybody's good with the pediatric compensation. Looks like I am a pediatric trying to draw things on the screen, but my little 3-year-old hand drawings. All right. So moving on, right? We again, patient is now urgent, so we immediately transported, right? So now we have the other things to worry about. He's 3 years old. How are we going to transport him?
In a car seat.
In a car seat? Does let's go back to Mrs. Klein. Does Mrs. Klein have a
What?
car seat?
Well, it said in the textbook never to use like the patient's own car seat. So like what other car seat?
Never
would
use
you
the patient's own car seat. Always use the patient's own car seat.
I swear in the
Wh-
textbook it said don't use the patient's own car seat.
Someone find their textbook because mine's out in the truck. And whoever it is, hit me, let me know, and you can screen share in the textbook where it says never, because we always use the patient's own car seat.
Which
We do not
section is
have
it? I have my
them
book here.
I know it said not to use it if it was involved in an accident.
only if there is significant damage. And otherwise, you take them right out and they're already stabilized and you transport them.
Does the illegal daycare have a car seat?
Does the illegal, no, the illegal daycare does not have a car seat. Mom
Wow.
forgot to leave it when she dropped them off.
Guess the mom isn't too on top of things.
Okay. So, I mean, they're three.
Trying to sound more illegal, you know?
I mean, it was pretty illegal, but whoever left kids in Mrs. Klein's care should have just don't deserve to have kids, but I guess I never met Mrs. Klein before. All right, so there's no car seat. What else are we gonna do?
Are we allowed to put them in the stretcher? We just have to be careful about how we, you know.
So, and we'll talk about this when we get to transport options, which is where I wish we could talk about that sooner. We do actually have little pediatric car seat devices that like take the adult straps and turn them into pediatric straps so that we can put them on the stretcher in the worst case scenario that we have to use just the stretcher. So that is an option. The other option is the captain's chair. The seat folds down. There's usually a pullout in the middle of the upright part of the back of the chair, and you pull that down and that turns into a child safety car seat. It's got a harness in there. It's got the pad they sit on. You literally stick them right on there and you strap them in like you would a normal car seat. And then you usually sit on the head of the stretcher and continue to do your assessments. So we will go with, we use the, for a 3-year-old, we could probably use the car seat in the captain's chair. All right. Obviously this one's not in. Do not use the pediatric patient's own car seat. Why would you not? That is all we ever do. Do not use the pediatric. What? Anybody find it in the book yet?
Yeah, I was gonna say, I'm looking, I can't find anything that even involves, like I found transport, but I haven't found anything that involves how you would transport. It just says why.
I'm trying to find the I'm trying to find it in the pediatric protocols to see what the state of New York says. Needle stick medications, interfacility. All right, well, we will come back to this. I will look it up in the next break. Or I will just go to the pediatric transport CME and find out what they say to do in that. However, I can tell you in the 10 years I've been doing this, you put them right in their car seat and then you strap the car seat to the stretcher like it was in the back seat of your car. You put the back of the board all the way up of the seat and you sit this car seat the way it would in the car, and you literally strap it down the exact same way. Or you use the pediatric transport devices that we have in the truck if they don't have one, but we've always
When I
used
was in the emergency room, I remember when I first like got there, there was this baby. I don't know how old it was. It was just in another room. And I guess something was wrong. They wanted to transport it to Mid Hudson. And NDP actually transported it. And they put, you know how like babies have like little carriers that the parents hold? Well, they
Yeah.
put the baby in the carrier and then put the carrier on the stretcher. And that's how they transported it.
They could do, yeah, you could do that too.
Okay.
But usually the carrier just is part of the car seat. So I usually have them go out and get the base out of the car. Because most of the carriers these days are part, like they click in and out of the car seats. So. All right. So now history. How did we say we wanted to? Let's go back. Let's rewind time a little bit. Let's go
Cool.
back to when the patient was still sitting on the floor before they started
Wait,
seizing.
I just found the slide on like the car seat, and it says do not use the pediatric patient's own car seat, and it's under primary assessment.
Yeah, we just had that. That was just
Yeah,
on the screen. Yeah.
but it says don't use the pediatric patient's own car seat.
Yeah, that doesn't
when
mean I
trans-
agree with them.
Okay.
That doesn't mean that's what we do. That's I'm trying to figure
Okay.
out why it's there
So-
because that's not what we do at all.
Okay.
That's gonna
who
be one of
makes
those
the
things where you're
slide?
gonna answer, do not use it on the test. But like when you get out in the field and you're with somebody who's been doing it for a while, they're gonna throw they're gonna throw a car seat on the stretcher and strap it down.
Okay.
And that's how it's gonna go. Like I'm trying to figure out why they would tell you that because that's the safest way to transport them is in their own car seat. We don't have anything. Like in the ambulance, we have nothing to transport pediatrics with unless they can fit and they're big enough to sit in the captain's chair car seat, which not every child is. Like a newborn cannot do that. And the little pediatric thing we have again is like not the best option. So like we always use their yeah. No, when we take the next break, I will pull up the pediatric transport CME and we might watch it and that might be the end of class. And then we'll go over the other stuff the next day. Huh?
Okay. I'm down with that.
It might be like we might, or if I can fast forward to the part where it goes over car seats. Like maybe I'll watch it off in the corner here, and then when we get to the appropriate part, we will we'll take a second and look at it. But apparently, for your test, do not use the pediatric's own car seat.
I've got something along those lines I've pulled from the internet. Michigan refers to NHTSA, and they say don't use it, but they also say unless you don't have any better choices. So I'm guessing it's like nationally frowned upon. And
I guess it's naturally frowned upon, but like I said, we don't have better choices for newborns. I mean, up to the age where you can sit upright in a car seat by yourself, and we can throw you in the little captain's chair car seat. But I mean, next lab, I'll bring the ambulance back over, and you guys can see what I'm talking about. Like you can't put an infant in these two little devices.
Hey,
all right, well,
Dustin,
It's not
oh,
safe.
sorry.
Huh?
according to the pediatric guidelines for the state, child's own safety seat, when available and intact, should be used to restrain the child during transport.
Yeah, well, that's the state of New York, but I guess that's not the national level.
Okay.
So in the state of New York, when you're a New York EMT, please use the patient's car seat. When you're taking a national exam, please do not use the patient's car seat. All right, this is just one of those where you're gonna have to answer take the test question the way it's intended. I won't ask you that question because I don't want you guys to get confused. But if you see it on your national exam, just remember, do not use their own car seats.
The ambulance service does not have an ambulance equipped with a child safety seat or restraint. It is strongly recommended that the agency purchase an improved child safety seat for each ambulance. So something more to carry.
I mean, technically, we have those little pediatric transport things, which is what
Right.
gives us the ability to say that we
It does
have them,
mention
but they're
captain's
not,
chair.
huh?
It does mention the captain's chair as an option if it's equipped with that.
Yeah, but again, you have to be big enough to sit in it. That's the thing. Like, I wouldn't put anyone less than 2 years old in that chair.
Yeah.
And then depending on their size. But like I said, I'll bring an ambulance in and we'll show you the next time we do a lab. All right. So again, we'll go history real quick. All right, we kind of got off topic a little bit, but histories, okay, if they're that young, right, up to preschool, we should be talking to Mrs. Klein at this point and find out what her Alzheimer's demented self is doing with a daycare in her house. Right, but adolescents, once we get to adolescence, we can start asking them questions. And like we talked about in gynecology, right, we can separate them from the parents if it's something that they don't want really to talk about. Okay, but keep your questions limited to the child's chief complaint. All right, don't let the parents kind of pigeonhole in one direction. All right, like Carolina said though, like everything might be my tummy hurts and they don't understand why. Okay, so try to figure it out the best you can. This is where you really got to put your detective hat on. All right, again, and I heard people talk about these things, right? The length of the sickness or injury, how long were they crying on the floor, right? The key events leading up to it, the fever we kind of got into, right? Is their behavior level been the same, their activity level, right? Someone asked what were they eating or drinking. Okay, so you guys are all on the right track. Okay, changes in bowel habits. Obviously, this person apparently had poop anxiety. So there was abdominal pain, right? And then this last one, right? They need to go with you. All right. If you're at the home with the parents, like you wait until the parent can come with you, or you take everybody. And if that means you're taking 6 kids and the mother, then you take 6 kids and the mother. All right. Because the hospital's going to freak out if you bring them a child with no parent. All right. Unless there literally was no one there. Okay. And then hopefully, if they were actually at like a daycare or something, then they have the name and number of the parent and someone meets you at the hospital. All right. But whenever you deal with a kid, unless it is, what is that? What is the consent that we operate with kids under?
Emancipated.
No, not emancipated.
Oh,
Consent, way back to like chapters 3 and
Lied.
4.
implied.
Implied consent, right? So unless it is a case of implied consent where the parents are absolutely not around and something happens, like a bunch of kids were out doing some dumb stuff, okay, and then one of them got smart and called for help, okay, you want to take a parent with you or have someone there notify a parent that can meet you at the hospital. All right, and then sample and OPQRST are the same, okay, based on age and developmental stage. All right, so just remember who you're talking to, where they're at. All right, you might have to change up your questions just a little bit. All right, and then our secondary, we did a lot of, okay, so we went down and we did the whole body assessment, right? We found the rigidity, okay. Usually we go, instead of head to toe, we go toe to head in infants, toddlers, and preschools. Mostly because that's where the problems end up being versus the head to toe. I don't know why. It's just, that's the way they tell you to do it. Right. So again, we did these, right? We look for bruising, swelling, hematomas. Again, I told you about the fontanelles, right? If they're depressed, sunken, it could be trauma, injury, dehydration, right? So look to see if they're congested, if there's mucus, right? Get that little bulb catheter syringe, suction, right? The bulb suction. Just get it out of their nose so they can breathe again, right? We talked about drainage from the ears and battle signs. Okay, if you see pus anywhere and they're warm, right? Fever, infection, expect sepsis. All right, active bleeding, loose teeth. Again, children can be diabetics, so note the smell of the breath. All right, examine the neck for swelling or bruising. Look at the chest, right? Feel all the bones, make sure there's nothing deformed. Okay, again, you know, it's an unfortunate side effect of society, but children do get abused. Okay, so we check everywhere, we check everything. We look for hand marks, handprints, lacerations, bruises, rashes, right? Look for distension, anything, seatbelt abrasions. Okay, do the arms and legs move at the same time, with the same strength, right? And then we do range of motion. So like where you can ask an adult what hurts and they say their knee. Like you ask, like Carolina said, you ask a child what hurts, they might say their leg, but they won't tell you. So we move the leg and we move each joint insignificant or independently of each other. And we find out, we wait for the grimace to see what hurts. All right. So vital signs, again, we assessed. All right. Blood pressure, you, like I said, you're not really going to get in someone less than 3 years old. They're not going to let you do it. If you do, congratulations. Right. So that's why we do more of the skin and the cap refill. Okay. And then again, make sure that you have the proper equipment to do pediatrics. There's a newborn size, an infant size. There's a toddler size, and then there's like the actual pediatric size. So not many people carry all 4 of them. Oh, look, the formula's right here. See, I didn't even have to do it. They already put it in here for me. All right. So again, if you can't remember the ranges that my brother gave you guys earlier through the video or whatever, the formula's easy to remember. And really, systolic is all we're kind of worried about. All right. Respirations, that's the way you should be doing everyone's respirations, right? You hold the pulse for 30, double the number, and then you continue to hold the pulse and count respirations for the next 30 and double that number when you're doing, right? Is that how they taught you guys how to do your vital signs in lab?
Yep.
Okay. So, and again, if you have to belly breathe, or count the belly, right? If they're belly breathing. Okay. Do the pupils, make sure they didn't get in anything. Right, the pulse ox, all that good stuff. And kids are the same way. Right, we're going to reassess every 5 or 15, depending. And we're going to see if anything that we did or interventions made things better or worse. So, all right, let's take another break. I have to use the restroom. And then we will talk about emergency management of the pediatric patient. All right, so we're going to talk about respiratory emergencies, right? Because I told you guys that that's pretty much the #1 cause of most pediatric complaints. All right, and they're also the #1 leading cause of cardiopulmonary arrest, because when you stop breathing, your heart can only go so long before it stops because it has no oxygen, right? So again, children react with behavioral changes. Okay, so they might get combative, restless, anxious. All right, they're not very good at telling us what's wrong. That's what makes it so hard. We kind of got to try to figure it out on our own. So, okay. Always look out for that nasal flaring. All right, we talked about abnormal breath sounds. We already used the tripod position. Okay, that accessory muscle use. Anything outside of normal belly breathing, right? Any type of abnormal sounds. Okay. When they start getting tired, all right, that's your cue for concern. All right, because again, like I said, once they start decompensating, it goes quickly. Okay, so if they start decrease in their efforts of breathing, or that chest rise and fall gets lower, all right, there's nothing left. There's no energy left. There's no, it's not going to go on for much longer. All right, so again, just remember that curve. All right, so again, the behavior, right, they'll be altered, they'll become hypoxic. All right, so they'll start slowing down, they may get groggy, they may get confused, all that good stuff, right? You may see them stop breathing for a couple seconds, right? You say, hey, they wake up, they start breathing a little bit again, then they go apneic again, right? So then the heart starts eventually slowing down. Okay, so it doesn't always have to be from an airway obstruction, right? They don't always have to have swallowed something or done something, okay? They can be for whatever need, from some sort of morbidity, whatever. Again, give oxygen just like we would normally, right? That's the whole point. Sometimes you give children oxygen, the problem resolves itself. Okay, so if they won't put the mask over their face, at least do blow by, right? Once they start becoming less and less alert, you can get away with putting the mask on. You can get away with doing the BVM for you, right? Let them sit in whatever position they're comfortable in, okay? Because they have to be able to trust you. So don't try to keep moving them around, tell them they have to do certain things and go over stuff, right? So what just happened? All right. So we're gonna do something a little bit differently. If I can find it. Nope, we'll start with the next one then. All right. So we'll go over this one. So obviously airway obstructions is the first easiest one we can solve. All right. And God knows what they put in their mouth and their nose that they swallow. Okay. Just about anything. Be aware in the case of traumatic incidents that it could be their teeth as well. All right. So same as adults, right? Blood, vomit. We suction that stuff out. Okay. Again, open their mouth, look, right? We'll talk about croup and epiglottitis differently. Okay. So we're not gonna talk about epiglottitis here. All right. Basically, we're going to talk about foreign objects. All right. So it doesn't always have to be complete. Again, like adults, it could be a partial. You may hear that like whistling sound, that upper stridor, that upper wheezing. Okay. So we're not going to really worry about that. Again, you may hear the decreased breath sounds, but like what I said before, they're hard to hear. All right. So definitely go with that stridor or that wheezing. Okay. Again, breath sounds for kids, we didn't really talk about, but you would do apical right at the top of the chest and then the armpits. Okay. And then you could probably do the back too if you wanted to, but the best way is in the armpit level. All right. That's where you're going to get the best overall view of what's going on. All right. Again, we talked about this during BLS resuscitation. Okay. Try to get them to cough. If you have to, do the back blows. All right. Give them oxygen. Okay. And then, you know, obviously, if you see any of these signs, right, just be prepared. Definitely do the back blows and the chest thrusts. Right. Someone walk me through how do we do that again? What did we learn in CPR?
I'm sorry, I missed the question. What was it?
Well, how did we learn how to clear an airway obstruction in CPR?
Suction. no more than 10 seconds?
suction. Well, that's if it's a liquid airway obstruction, but let's
Oh, we're
say
gonna
it's,
do the Heimlich maneuver, right?
well, not in
Except not with,
children,
yeah,
right? So
Not
how do
very-
we do?
Oh,
The
the
back
backslash?
slaps.
yeah,
And
the
then
back slips.
the
Yep. So someone walk
Weird
me through the
compression bit.
technical back slap. How do we do it?
You're gonna turn the baby over and you're gonna have them on your knee, facing like down on an angle, and you're gonna, with like the hard sole of your hand, kind of like hit between the shoulder blades.
Okay. How many times?
5.
5. And then what do we do after that?
Flip them over.
Okay. Then what do we do?
Look and see if anything came.
Yeah. Look and see if anything came out. Then what do we do?
It's the weird kind of chest compression things, isn't it?
I mean, yes, there's chest compressions, but what does weird kind of mean?
Like you're holding them like a controller.
Game control.
No, it's not the game controller one.
Isn't it the 2 fingers?
Yeah, it's the 2 fingers.
Uh,
2 fingers over the breastbone for airway obstructions. Game controller is when you're doing 2-person rescue CPR. Good. So we're gonna
And
get rid of the airway, right? We're gonna do this. Okay. And if the child is large enough, we can do the abdominal thrusts. Right. We can do the Heimlich maneuver, but
not call it that.
just
Not call it that.
not call it that, right? We're not allowed to use Heimlich. Okay. And then obviously once we can see it, we can get it out, we get it out. Or we continue to do CPR if they remain unconscious, right? Okay, asthma. All right, so we all know what asthma is. Now, I have these nifty little, hold on. How can I do this? Oh, how can I do this? All right. We're going to talk asthma, but we're going to do it in a scenario based, kind of like we did the first one. However, you guys aren't in charge of this one. Like I have actual things, so you guys have to get there. So let's do it in groups of 2, and we will go through the rest of them. So who wants to be the first group of 2? And then if anyone has any questions or concerns, then you can buzz in and be like, I don't know if I would do it that way. And then we can talk about it. So who wants to be the first pair up?
I can do it.
All right, who wants to be Lyra's partner?
I'll be Lyra's partner.
Oh, who was that?
Oh, Isabel.
All right, Lyra and Isabel. You, nope, back to where I was. All right, there we go. You're responding to a 10-year-old female with difficulty breathing. Caller states that 2 breathing treatments have been given with no improvement. Caller says this was a sudden onset and the patient does have a history of asthma.
Okay.
Okay, so you arrive on scene and go.
Okay. We can like make up the scene. Like we can say she's at home.
Nope. You're gonna say
Where is she?
the patient is sitting on the front porch with adults and a few other children of the same age.
Okay.
It's an August evening with an ambient temperature of 82 degrees, dusty and dry outside.
So we arrive on scene and we have our PPE.
Yep.
Um,
and the scene is safe and we're like approaching the patient.
Okay,
So she's the only patient?
she is the only patient for right now. Yep.
Okay. Mm,
Okay, so
So what do you want to know? What are you gonna do, and what information do you need?
well, if we need to call anybody else, so
Okay.
maybe like, well, she's having a breathing problem. So maybe ALS, or if, so well, since she had already medication, maybe like med control.
We can call ALS. We can get that going for you. They're on their way. What do you want to do in between then? What's part of your scene size up?
Well, I mean, I don't think C's fine. I mean, I consider it, but I don't think we need that.
Right, we consider it. We don't have to do it, so we considered it. What else?
AVPU, so we can like try talking to her and see if like
Okay, so you want to know what your impression is?
yeah.
Okay, your patient is sitting with her arms tight to her body, pushing against the concrete step. Patient is leaning forward at the hips. Mouth is open, skin on the face is noted to be pale and damp with sweat. Patient looks up as you approach.
Okay.
So she is
So-
alert.
Yeah,
Mhm.
she's a
Yep.
and then so well her chief complaint is that she's struggling to breathe.
Difficulty breathing. Yep.
And so then we can we at this point move to like ABCs?
Sure.
So then we'd like assess the airway and I guess we
Okay. So the airway is open and patent.
could we like and like we could can we apply, is it like too soon to give supplemental oxygen?
So for your test, yes. In real life, no.
Okay.
All right. Go. Yeah. So
So
follow your sheet for right now, just so that you guys don't get confused and don't get your points taken away from you when you go to do your practical. Until we start working in more in lab, just go by with what your book wants you to do right now. So you did A, so we'll talk about B next, right? You want your breathing? So
Yeah.
there's equal chest rise and fall noted. There's audible wheezing in the upper lung fields. There's minimal air movement in the lower fields. And you notice shallow breathing with retractions and accessory muscle usage.
Okay.
And her circulation is fine.
To manage airway and breathing, now we could give her supplemental. Or
Yeah.
is it
Nope. Now you can do it because it's a life threat. So you can treat that now. Yeah.
okay. And then at this point, so then we can do like it's already been noted that like her skin wise, she's like her face is blue. Right.
Skin on the face is pale and damp with sweat.
Oh, okay.
I don't think I've seen blue anywhere yet, but
So then we would assess like her skin color and temperature.
okay. So skin is warm, pale, and damp.
Okay.
And like just check for like a presence of a pulse
She does
and
have a
like the
pulse.
quality and stuff.
It is regular.
Okay.
And she's not bleeding, is she?
There's no bleeding anywhere.
Okay.
And then should we move into like the secondary assessment and do her vitals?
Well, where are you guys on the assessment tree? How far did you get so far?
Well, we did the ABCs, right?
Yep.
So then we need to identify if she's a priority.
Okay.
I would say yeah, because she's
struggling
not breathing.
Okay. So we can make her a priority.
Okay.
All right, so you want to go into your secondary?
Okay.
Okay, go into your secondary. What do you want to know? Or what are you going to do?
So we're gonna do vitals, right?
Sure. One of you is doing vitals. So her blood pressure is 110/52. Her heart rate is 134 in regular. She's 48 respirations in labor. And her room O2 air is 88%.
So, okay. So the pulse ox is low. So, oh, but she's on oxygen already, right?
Yeah.
Well, this one says her room air is, so we'll say she took it off because she didn't like the mask.
Oh.
We'll say she's non-compliant.
Oh.
So now you got to try to figure out another way to put it on or do something different.
Can we switch to the nasal fluid? Like
What else do you
the
want to do?
nasal?
So she has asthma.
Yeah.
Okay. So she did some breathing treatments with no improvement.
Mhm.
Okay. So
Could we do albuterol?
you can do albuterol, yep. Okay, so let's give her another breathing treatment. That's a good idea. All right. So because we don't know how long ago those two were, it just says that they had given them to her, right? So we'll give her another one. All right. So while she's doing her inhaler, what else do you want to know?
Well, like her sample history. So
Okay.
allergies, medication.
So she has no allergies. She's on an albuterol inhaler. She has a rescue inhaler when she needs it. She has a history of asthma. She ate dinner about an hour ago. And the events leading up to it is the patient forgot to take her inhaler this morning. Patient was playing with her siblings outside when she started gasping for air.
Oh.
All right, what else you want to do?
Well, has she improved since we gave her the albuterol?
Huh?
Has she improved since like her last dose of albuterol?
Is this the one you gave her or the one she took by herself?
Well, the one we gave her.
The one you gave her. So you want to do another set of vitals?
Yeah.
Okay. So her new blood pressure is 99/62. I'm praying you guys are using machine. Her heart rate is now 128 and regular. Her respirations have slowed a little bit. They're 44. Her O2 is now 94% with the neb and the oxygen. And her blood sugar is 87 because apparently you guys decided to take a blood sugar. Being very thorough.
Well, always.
Wait, how old is the patient?
10.
10. Okay.
All right. So what else you want to do? What are we
Wait.
concerned about?
What was her respiration?
They're still 40s. They're in the 40s. But her O2 is getting better. So she's doing okay. She's coming down a little bit. What else do you want to consider? Ladies, what else would you like to consider?
I'm thinking.
Okay. Well, I can't see you visibly thinking, so someone help her out. What else would they like to be thinking?
I'm thinking maybe transport, or because I mean she's getting better, but like her respirations are 40 when
They're in the
they're
40s,
like,
yep.
so but they're supposed to be like 18 to 25, so she's going pretty fast.
Yeah, she's a little fast for her age, but again, her O2 is coming up and her breathing is coming down, right? So we're not overly concerned yet, right? So
Okay.
why is your albuterol working and hers didn't?
Is hers
Was it expired?
There we go. All right. Maybe her albuterol's expired. Okay, so someone goes inside, checks the house. All right. The albuterol was expired in the house. Okay. So we've informed the parents that they should get some new medications. All right. What else? Asthma can also be what? What are causes of asthma?
Well, overexertion, right?
Okay, overexertion. What else?
Environmental.
Environmental. Yep. Now, what was her environment?
It was a
Well, she's
dusty,
playing with the kids, right?
Yep.
dusty hot day.
Right. Dusty, dry, hot day. Okay. So what else do you want? What else should we do?
Maybe like move her to like, well, she's on the porch, so she's still outside. So
She's still
like
outside,
move her
right.
inside.
Okay. Well, do you want to move her inside or do you want to move her to your truck? Right.
Mm,
How many times do you want to move the patient?
well, if we're transporting her, then I take her to the truck.
I would probably transport her.
Yeah.
I mean, again, it's gonna be up to the parents, but yes, I would have that discussion and make that decision before we moved her one way or the other. All right. But if you want to move everybody inside first, all right. I like to tend to only move people once if I have to. All right. So if I know I'm taking them somewhere, then we'll go to the truck. But if there's a possibility that they're gonna stay home, then we can move it inside. But yes, let's get her out of the environment she's in. Good job. All right. So other than transport, right? Anything else? I mean, you really can't do anything else.
Yeah.
That
Oh,
that
okay.
this one really needs. She needs steroids. Is what she needs. But there's nothing. Yeah. You guys can't do that. So that was a good job. Anybody got any questions or concerns on the asthma management? No? All right. Okay, so we talked about asthma. Let's do pneumonia. Do I have one in here for pneumonia? I do not have one in here for pneumonia. All right, let's talk about pneumonia though. So what is pneumonia? No? Yeah, I can give you the answers on the screen, right? So pneumonia is basically a lung infection. All right. And it's mostly the fluid that comes from the lung infection from the buildup of the bacteria and all of that. All right. So we worry about child pneumonia because, again, it leads to difficulty breathing, which usually leads to cardiac arrest. All right. Because they're basically drowning in their own fluid. Okay. So there will be some unusual rapid breathing. All right. There should be wheezing, crackles. All right. You're definitely going to hear some sort of wet sounds over the infected areas. Probably a fever. Definitely tachypneic. There probably all sorts of whatever signs of trouble breathing you can think of. Okay. And again, there's nothing we can really do. You can give them a little bit of albuterol if they're wheezing, just to try to open up the airway a little bit, and you can give oxygen. Hopefully they start coughing up some of that stuff. All right. But for pneumonia, basically to the hospital is the best way they can do it. All right. So croup, who wants to tackle the croup scenario? Give me two.
I'll give it a whirl.
Joe wants to go. Who wants to go with Joe?
Sure.
Joe and Phil? All right. Joe and Phil, you are called to an apartment complex for a 4-year-old female having trouble breathing. Patient was asleep, woke her mother up saying she was coughing. Patient also has a fever and mother has no medications to give her at home.
Cool.
It
Mask
is
gown and eye
January.
protection.
It is 18 degrees outside. It is 2:30 in the morning. A young child is seen waving you down in the middle of the roadway and directs you towards the apartment. You enter the apartment to find a female holding the child on the bathroom floor. The shower is running.
Shower's running.
The shower is running.
And there was
Yeah,
just this other random kid outside.
Apparently that's the brother or sister. I don't know. I don't write these things.
Okay.
I just like the detail that these ones have. They literally have the answer to any question you could think of. Except for Joe. Joe will find the one they don't.
Could we get everybody in where it's warm for now?
Sure, let's get one of you grabs the kid outside and brings them inside. All right, so everyone's inside now. All right, so what do you want? What do you need? What do you want to do?
We'll cover the BSI, seen a safe stuff.
Yep. Now the kid's not waving you down the middle of the street.
All right, just to review, it was a 4-year-old.
4-year-old female, yep.
4-year-old female who woke her mother up with a cough. Is that
Yep.
what I'm at? Also has a fever.
Yep. Did we say fever? I don't think we said fever yet.
You said fever.
Oh, patient also has a fever. Yes, and mom doesn't have anything at home to give her.
Okay,
All
well,
right.
first,
Go ahead.
sorry, I'm going over a list in my head.
That's fine. What's the first thing you want to know? Or what's the first thing you have to do? Right, you did your BSI,
Well, we
seemed safe.
technically went through the scene size up.
Right, well, you didn't do the one
Consider
part
she's
of it.
fine, but they kind of just have a cough and a fever. I'm gonna ask the mother, hey, did they like slip in the shower recently, something like that? And if not, I'm gonna be cool.
Okay. So let me give you your first visual impression. Patient is in apparent distress and only looks at you for a second as you enter the room. The child is limp and wearing a pull-up and t-shirt. Patient is noted to have deep bark-like cough with no mucus production.
All right, so this is, let me think. This is the only kid that's coughing?
This is the only kid that's coughing, yep.
All right, coughing. Let me think. We're going to rule out any C-spine implications, i.e. slips in the shower or other falls from earlier in the day.
Right, yep, nope, no C-spine stuff, you're good there.
Personally, my initial gut reaction is kid has fever, is coughing badly. Get an ambulance and continue observation there.
That sounds like a plan, we could do that.
Yeah, that's fine. Croup is a particular type of cough, right? It's supposed to be a lot louder,
Yep.
more severe sounding, but not necessarily any more dangerous than any other disease, right?
Well, so it's the deep bark-like cough, all right, and there's no mucus. So what happens is that it is an infection in the airway below the vocal cords, and it is usually a tightening of the airway. So you're dealing more with an airway management scenario. It's not something we sit around for.
Okay.
Because
well,
that airway could swell shut pretty much at like any minute.
this is supposed to be a secondary consideration of COVID, right?
Yeah, kind of.
All right, so how does this kid look?
Patient is in apparent distress. They are limp and they have a deep bark-like cough.
What's the skin look like?
The skin is pink, hot, and dry.
Pink, hot, and dry.
Do we want to ask the kid some questions?
Yeah, probably.
Kid only kind of looks at you, doesn't really want to talk right now.
So we ask the mother questions.
Can you ask the mother questions? We can ask some other questions, but let's go back. What else?
Especially want to do ABCs.
There you go. Let's go with
ABCs. I didn't feel like we were there in the sheet yet, but we could do that if you like.
ABCs are the first thing we got to do after.
I was gonna say, why are we asking questions if we haven't done ABCs yet?
Yeah.
Well, because that's how you establish whether the kid's alert and whether the kid responds to verbal stimuli.
Oh, you want to know those questions?
Thus far, we don't know that because the kid isn't talking and we haven't established whether she's capable of talking.
Well, the patient does speak in 3 to 4 word sentences, however, like would not like to.
Good enough for me.
It's not comfortable for her to do so. All right.
Okay.
So airway.
So if the kid's
you-
speaking in 3 to 4 word sentences, I'm going to go ahead and conclude that the airway is not blocked because they're speaking.
Right. The airway's open. Breathing is equal chest rise and fall, shallow inspiratory stridor, and slight retractions noted with no external trauma shown.
Okay.
And the patient has a pulse that's regular. And you asked about the skin, it was pink, hot, and dry.
Would we throw a pulse ox on this kid?
We can throw a pulse ox on this kid. It is 92% right now.
Then we go grab that oxygen. And you said the kid's 4?
Yes.
So wouldn't we do like the breathe by? I think it's called something like that.
The blow by, we can do blow by.
Yeah,
Yep.
blow by.
Don't they have a kid mask?
There are kid masks if they'll put it on. Sometimes they
I
don't
will-
necessarily. Ours look like little purple elephants. But yeah, no, it depends.
Yeah, first we would probably attempt the kid's mask, and then if they are refusing of the kid mask, do the blow by technique.
Yep. So the kid's being nice and he lets you put the mask on.
Did we get a pulse rate?
You didn't get a pulse, you just got a regular. Are we doing a full set of vitals now?
That's part of, we just wanted to check to see if it was there and on both sides and strong or weak or whatever.
Yeah, no, the pulse was there, it was regular.
Yep.
All right, so we would have to update
So we did the airway,
responding
we did
EMS
breathing.
units, right? Or something
Yep.
along those lines. Call it in. Call what we
Sure.
got in.
So you got your ALS on the way, what are you gonna tell them?
That we'll meet them en route.
That's good, but what are you gonna tell them? What's going on so far?
I have a 4-year-old female presenting with a loud barkish cough, low pulse ox, and difficulty breathing,
Sure.
along with I
Did we get it?
remember you said Strider for her breathing sounds. Was there? I think there was.
There's
another one.
Strider, yep. Did you get a what, Joe?
Did we get a number on the fever?
101.4.
And with a
PVH.
fever of 101.4.
Okay. So what's next? What are we doing next then?
Well, we're on the road, all right?
One of us
Right,
drives.
yep,
while the
Phil
other
wants
one
to
gets
be on the road,
secondary assessment.
so, all right. One of you is now driving and is out of the scenario. Who wants to take over patient contact?
We can't both contribute to this.
I mean, you can, but I'm just saying, like,
Out from the
I'll be
front.
driving because I have some
what's next?
experience.
Ask the mom some sample stuff.
Sample stuff. So your signs and symptoms are labored breathing, hoarse and deep cough with a fever, no allergies. They only take a multivitamin. There's no medical history. They ate dinner at 6:30 and the patient was sleeping in a room. She has had a cold for the last several days, woke up coughing and woke her mother up.
Did they keep dinner down?
Yep.
Okay.
I guess we would take the regular vitals at this point.
Take the regular vitals. Blood pressure is 110/60. Heart rate is 130 and regular. Respirations are 16, still labored, but they're 96% because you put them on O2. Their GCS is 15, and again, being thorough, you guys took a sugar and it's 72.
What was the 130?
That's her pulse.
Yeah, but children have faster pulse rates, but that's still a little high, isn't it?
Yeah, that still feels high. I think 130 is high for a kid.
For a 4-year-old?
Maybe it's not. I don't have the reference guide in front of me.
Gianna, let's go to the notes.
What was that?
What is the average pulse rate for a 4-year-old?
Hold on.
3 to 4 is 80 to 20 or 80 to 120 beats per
80
minute.
to 120. So she's a little bit over it.
Yeah.
All right.
Hey, memory.
Are we worried about 10 though?
Not really.
That's
I'm a
all right.
little worried.
Terrible.
Not. I'm
I'm
not
about
stressing.
10 points more worried than I was before.
I'm not
Well, I
stressing
mean,
130.
Yeah,
Like
130 is
my
not
heart rate
bad.
rests at 130 sometimes, but that's because I probably have something wrong. So, you know, I don't know, it could be different for everyone. Like I remember it was a firefighter thing I was doing, and they brought in paramedics for a couple people and they're like, oh, we should check you out. My heart rate was resting at like 150, and they were like, you're really tacky. And I was like, oh yeah, that's fine. They're like, it's not though.
Did we get all aspects of the OPQ RST?
OPQRST. Yeah.
Is there any
there's
pain?
there's no pains at 2,
Yeah.
but they
Okay.
don't. It's mostly just throat pain from the cough.
Okay.
There's no OPQRST stuff.
I feel like we've got what we needed.
Yeah. No, you guys are great.
Agree with
You
you.
guys got everything on there. You asked about other family members being sick, right? So on really with croup, the only thing we're worried about is keeping the patient calm. All right, because again, that airway is already constricted. So we're trying not to get them to, do anything else to make it worse. Again, when we're transporting, heat makes it worse, right? Heat makes the infection kind of swell a little bit more. So we don't really keep the heat on, but we don't make it super freezing either. We kind of do the best we can to manage it. And then, yeah, you just transport them to the nearest facility. Get ALS if you can. There's not much I can do for croup either. It's just O2 and airway. They don't get steroids, don't get anything like that. It's an infection. It needs antibiotics. So by all means, feel free to call, but it's not something that you need ALS for.
Is this a 5-minute reassess or a 15-minute reassess?
I would reassess the airway every 5 minutes. The vitals, you could probably do every 15. Her vitals are stable. So croup is an airway management. That's all it is. Airway management and O2.
Okay, then.
Right. And if you have humidified oxygen, it works a little bit better, but giving them regular oxygen is just as fine. All right. Who wants to tackle epiglottitis? Two more. Who's up? Don't all volunteer at once. Let's go with. Oh, Gianna wants to go. Who wants to be Gianna's partner?
Hey, yo.
I'll do it. But how is it different than group? I'm just curious.
Well, we're gonna learn.
Okay.
All right. So where was? It's the place, right? So croup is a bacterial infection below the vocal cords, right? So epiglottitis is the bacterial infection of the actual epiglottis, right? That little flap that covers your windpipe when you swallow food.
Yeah.
Right. So this is an infection of just that piece of skin.
Okay.
All right. So
Is it our job to try and figure out the difference, or just to,
so you'll see the differences. Croup has that high bark, like seal, like cough, and you'll hear it from a mile away. Epiglottitis, they're not talking, they're not coughing, they're tripoding and they're drooling. Okay. Like there's no, and they usually have like a super high fever, like they'll be hot. But yeah. So I mean, if they're drooling, suspect epiglottitis. If they're coughing with a bark, it's croup.
Cool.
Okay.
Okay. So are you gonna give us like a scenario sort of what the test would be like? And we'll go off the sheet by memory.
I'm gonna do what I've been doing for everybody else.
Cool.
So
Okay.
it's exactly the same. You are responding to a 6-year-old female with difficulty swallowing. Patient is also having some trouble breathing. She has been sick for a few days, but this is a sudden onset and there is a lot of drooling.
All right. First of all, BSI.
Yep.
Today I have gloves, a face mask, might go with a shield. Gonna wait it out. Is our scene safe before we enter?
Your scene is safe. Upon arrival, a man waves from the front porch, then steps inside the open door.
Cool. All right.
As you walk inside, the living room is tidy. A female is noted to be sitting next to the patient. The male identifies as the patient's father, and the female is the patient's mother.
Cool. Okay. So is this my only patient? We just have the 6-year-old?
This is your only patient. Yep.
Cool. Okay. Well, I'm gonna request ALF just for now.
Yep.
They're on the moon right now, but that's okay. We'll do it just in case. Let's see. I'm gonna consider C-spine. I'll ask the mother first, like, has she fallen at all or hit her head?
Nope.
Probably not. Okay, cool. And MOI, NOI. Looks like we have nature of illness, slight difficulty breathing, and throat pain.
Difficulty swallowing, difficulty breathing. Yep.
Okay, cool. Am I forgetting anything in the size up?
Do we have to say chief complaint already?
I think, is that primary or
I think you need your impression.
general impression? Cool.
What is their general like impression for like skin and stuff?
Hold on. Let me go back and find this. Nope, that's bag valve. We don't need that one. Which one is it? 1 or 2? 2 is trauma. Yeah, once you're done C-spine, that's the end of your size up. You go into your primary, which is general impression, AVPU, chief complaint. Yeah, see, she was fine doing the chief complaint there.
Oh yeah, I wasn't questioning. I'm just making sure I got everything in the scene size up. Good job.
Yeah, scene size up is your BSI, your MOI, NOI, your number of patients, and your help and C-spine, which you guys did. So you moved on. Yep.
Awesome.
Okay.
So
So your initial impression is patient sitting with hands clutching edge of sofa cushions. Patient's eyes lift to meet you, and she looks very scared. There is a significant amount of drool noted to be dripping from the patient's mouth and onto the towel in her lap.
All right.
definitely gonna check breathing.
So the airway is open, and she is breathing.
Cool.
There's equal chest rise and fall noted. There's clear lung fields. You can hear
Okay.
Strider noted with her inspirations, and she's breathing shallow but not labored.
Okay.
Check her pulse.
She does have a pulse. It is regular and it is strong.
Are her respirations high too?
She is tachypneic. Yep.
Okay. Let's see.
Is she,
How?
is she drooling
oh.
enough that we would want to like suction it or anything? I mean, it seems like.
So yeah, we don't really suction with epiglottitis unless it becomes an airway like aspirational problem, because you don't want to irritate any more than what it's already irritated.
She's like very aware, so we just wouldn't do that really.
Right. Yeah.
Okay.
Not unless she started to decompensate. Would you worry about that quite yet? But it's a good it's a good thing to think about. Okay. So we're gonna think about suction, but we're not gonna do it yet. What's next?
Well, I want to get their AVPU scale level of consciousness, all of that. Am I allowed to speak to the patient now? Just kind of like, hi. You
Yeah, I
know,
mean, she's not really going to talk back too much. Her throat
Mhm.
hurts and she can't really form many words, but I mean, she looks at you when she calls her name.
okay, cool. So
Response to
responding to
similar,
voice.
but we should probably ask the parents like history.
Okay, so she's been sick with a sore throat for the last few days. Within the last 30 minutes, she's been unable to really swallow and the drooling keeps getting worse.
Like completely unable to swallow? Like
It
that's
says
actually
completely
still
unable to swallow, yes. Suddenly unable
concerning.
to swallow in the last 30 minutes.
Okay. So her throat's closing? Is that where we're at? Like she can't breathe now, or
Well, that little
Would-
flap is, yes,
Oh,
it is basically
oh.
swollen to the point where it is covering everything and that like it doesn't move when you swallow, like it doesn't get out of the way.
Would
are we
we
gonna have
want
to get an airway in now?
Huh?
Okay. Is this a situation where we would start transport and continue assessing?
Yes.
Yeah, I'm thinking
Yes,
that.
we would.
And
Okay.
that would be the
Yep.
next step. Yep. Do we continue with telling you what we would do, or is that?
Yeah, no, keep going. No.
Okay. I guess we'd do vitals. One of us would do vitals, and
Okay, so she is alert. Her blood pressure is 108/70. Her heart rate is 124 and regular. Her respirations are 30 and shallow. She is at 98% room air, and her GCS is 15.
would we still want to try and figure out oxygen? We wouldn't want to like hurt anything by like trying to suction or clear the airway too much because it's swollen. So like, what treatment can we do?
You can give her
Would
oxygen, that's
albuterol
fine.
help?
Okay.
Albuterol is not going to help. Nope.
Okay. So I guess we definitely have to get an airway though. Because her throat's closing. At least
Well,
that's
so yeah, but you don't want to, you're not going to mess with it because again, it's just that one little skin flap.
all right. Can we
Alright,
apply
so-
oxygen? Would that
Yeah, you can
be
give her oxygen,
beneficial?
that's fine. Yep.
All right. I think at this point, a non-rebreather would be more efficient than nasal cannula, right? Because
Well, I mean,
Well,
we
if
can
it's
do the drool.
oh, the drool too, yeah. Okay, well we can start with a nasal cannula then, at 2 liters.
Right?
yeah, I agree with that. Can we
Okay.
give them? I guess she probably can't swallow. We can't just give them aspirin, right?
Yeah.
No aspirin.
Sorry. Just asking all the questions I would possibly have in my head.
Okay.
But
Why would we give this person aspirin?
I'm just like thinking like maybe inflammation or something. But I'm just asking the questions while we're in class so I don't do
No, that's
something
fine.
stupid when I come
No,
across.
I mean, we definitely would not give this person aspirin.
Okay.
But, yep.
Yeah.
I mean, we
I
do
guess-
now have,
Can I ask a question on this, or do
Tylenol.
you want me to wait?
no, we can jump in anytime. Go ahead. That's what we're doing. This is learning.
I'm a little unfamiliar with how this biologically impacts this particular patient. Is it the flap is swollen so it blocks breathing, or is it the flap is swollen so it's an obstruction?
So the flap swells and then it basically cuts off not so much an obstruction, it doesn't function properly. So when you swallow, it doesn't close over the trachea the way it's supposed to. Because it's all swollen and mean and angry. So it kind of like in order to guard from basically aspirating, like they refuse to swallow. It's so painful to swallow, they won't. And that's why all the drool comes out. And they drool forever. But that flap can swell up enough and cover the very top of the trachea. So hold on.
So this isn't like a nasal route would be considered instead of an oral route because the airway is still impacted beyond that farther down.
what did you say? The nasal
Basically-
route.
Yeah, I was trying to establish whether putting air through the nose would be indicated more than putting air through the mouth because of where in the throat the blockage might occur.
So again, the only reason I said not the mask is because you don't want to cover the mouth because there's no place for the drool to go. Like it's all gonna stay in the mask. Like you want that drool to go somewhere. Where is the?
Well, I got a second. I think it's if you can't swallow, you can't take aspirin. That's kind of the thing, right?
Well, the aspirin's not really gonna do anything because an aspirin's not an anti-inflammatory. So
Right, but that's more of a general thing. If you can't swallow, you can't take a pill.
right, which is why I mean we do have whatchamacallit. We do have liquid Tylenol, but again, if they can't really swallow it, then
Swallowing occurs in 2 stages.
is this it? Yeah, hold on. Let's do this because this may explain it a little bit better visually than what I can do over the phone. All right. Can you guys see the video? Guy holding the apple.
Yes.
Yeah.
All right.
Swallowing occurs in 2 stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oropharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis initiated by the swallowing center pushes the bolus through the esophagus. As the bolus travels through the esophagus, the lower esophageal sphincter relaxes, allowing the food to enter the stomach. If the bolus is sticky and adheres to the esophagus, secondary peristaltic waves triggered by the intrinsic plexus at the point of distension completely clear the esophageal lumen to finish the swallow.
So when the esophagus is swollen, like it won't cover that trachea that way. It doesn't come down like it did in the video. Okay. And like you can't get that. It won't swallow. Where the hell is the picture? You always gotta ask me good questions, don't you?
Well, it basically, I think the video answered it enough for me. If the thing is capable of covering the entire airway and it's swollen, i.e. it's
So like,
larger
you
than
see
it
how
normally
it's swollen
is.
here? Can you see
Yeah.
the picture, right? This whole little U-shaped thing is the epiglottis. Like, you see how swollen it is? Okay, like that's not gonna, it's not gonna go down and cover things the way it's supposed to.
Okay, sorry to interrupt.
No, it's not interrupt. I mean, do you understand what's going on? Trying to figure out if there's a better way I can.
Yeah, I'm picking up what you're putting down.
I just want to make sure Joe gets it.
Yeah, it's farther down than I thought it was. I thought it
Okay.
It was a mouth only thing instead of a mouth and nasal thing, and it appears that it's farther down, so that both would be impacted equally because that's just where it's located.
Okay. All right, so let's go back to epiglottitis. Right, so where are we at? What else did you ladies want to do? Anything?
Assuming we
so
get him
we're
to the
oh
hospital.
sorry.
Oh, no, go ahead.
Nope, you're going to the
we're-
hospital, right?
Yeah, we're going to the hospital now. I would definitely reassess the airway, at least, if anything. Is it
Okay,
every
so the
5
airways,
minutes
yep,
critical, every
airway
15
stays
minutes,
open.
right? Okay,
No, this one, yeah, I
Cool.
would make sure every 5 is good.
all right.
Yep, so the airway stays
Cool.
open, the O2 goes up to, it stays at 98.
All right, good. Are they showing any signs of shock? Like, should I give them a blanket or anything like that?
Nope,
Cool, okay.
nope, you're doing good.
I'm assuming either on the way or when we get there, we'd give a report.
Yep, so what are we
And-
gonna tell them?
We have how old again? I'm sorry.
6.
We have a 6-year-old female who had a fever for 3 days was sick for, was it a fever and coughing or no, a sore throat for 3 days, and then had their airway obstructed and closed up within the past, what was it, like, it was the evening, or was it 3 hours or something? I'm really
30
forgetting.
minutes,
30 minutes, yes. Okay, great.
within the last
Wow.
30 minutes.
Yeah. And then we'd say like how long it's been since we got there, and that would be it, I guess, probably, unless there were other things that the parents told us that would be pertinent. That's
Yeah, no, that's
Yeah.
fine. Good job.
Yeah.
All right, so what's the next one? Well, can we do one more, or should we just stop and pick up on Monday? Bronchiolitis. We might be able to get through that one. That one's pretty easy. All right, well, you gotta do it in 10 minutes anyway. So next 2, give me 2 for bronchiolitis, otherwise known as RSV.
We're not allowed to go twice?
No, you're not allowed to go twice, not until everybody else goes.
Oh, okay.
I'll go.
I'll go. All right, who wants to be Carolina's partner? Don't make me pick somebody.
Yes, I'll go.
All right, good job, Melanie. Way to step up. All right,
My girl Melanie getting it done.
you are dispatched to the local elementary school. Oh. The school nurse states she has a 9-year-old male having trouble breathing and keeps coughing. The patient has had a cold for the last 2 to 3 days, and today is his first day back. Apparently, this is pre-COVID. School nurse advises they are unable to reach the patient's parents. So what do you want? Let's go through your sheet real quick, and then as you get to the things, I'll give you more information.
All right, so you said 9-year-old male coughing in school, right?
Yep, having trouble breathing and coughing. Patient's been sick the
trouble
last 2 to 3 days, and today is their first day back. They are unable to reach the patient's parents.
Okay, so this is when we are dealing with that implied consent thing, right? Because the parents are not there.
Yeah,
Okay.
go down your sheet though.
So-
What do you want to do?
First, you're gonna do your scene size up, of course.
Yeah. So what's part of the
So
scene
I-
size up?
Right.
BSI.
hmm I definitely want gloves,
Yeah.
possibly a mask if I don't know, since I don't know what I'm dealing with yet.
Okay.
Is the scene safe?
The scene is safe. It's early December, mid-morning, around 10:30. School security personnel escort you to the school nurse's office, where you notice the patient
Alright,
is on the
so we
exam
can
table with the nurse at his side and 4 other children with cold-like symptoms in the office.
Okay. So we see other children, but we want to focus on the patient that the nurse called for, so we'd have to determine which one is the patient.
Right. Well, she'll tell you. She'll bring you over to him.
Okay, and we
Right.
only have one patient, right?
Yeah, you only have one
Yes.
patient. The other 4 aren't getting called out yet.
Okay.
Right. So
Go ahead.
I wouldn't think there would be any necessary for C-spine because there's no external injuries that I see.
Right.
So we would roll out the C-spine.
Okay.
Do we need ALS?
Do you?
Well, he's having a difficult time breathing,
Okay.
so maybe.
All right. That's fine. So you call for ALS. We'll meet you somewhere.
Okay.
They're on their way.
All right. And then we move to primary assessment, right?
Yep. So what's so you want your general impression?
Yeah.
Patient
Please.
is noted to be struggling for air and restless. Patient has taken off his sweater and undershirt and is noted to be very sweaty. Wheezing can be heard upon moving into the room.
So I would definitely want to, since he is sweating rather bad, I would want to try to cool him down at least a
Okay.
little bit.
Well, why do we think he's sweating?
What you say he's restless and what?
Patient is noted to be struggling for air and restless. Patient has taken off his sweater and undershirt and is noted to be sweaty. Wheezing can be heard upon moving closer to the patient.
Oh.
Now he's having trouble breathing and he's sweaty. Why do we think he's sweaty? What else causes sweat?
Fever?
Fever. Okay. So as the first thing we're going to do, try to cool him down, or what are we going to do some other things first?
We're going to want to maintain that airway first,
Okay, so let's check on the
especially if
airway
he's having
first.
trouble breathing.
Right. So you hear wheezing. You
Mhm.
see equal chest rise and fall.
Okay.
There are retractions. And the patient is breathing rapidly but shallow.
All right.
All right. They do have a pulse. It is regular. And the skin is pale, warm, and moist.
All right.
Okay, so.
So I definitely want to put him on oxygen.
Okay.
Just so we can regulate that breathing at least a little bit.
Sounds good.
Hmm.
So where are we at on the sheet? Can you guys? I put the sheet up for you guys. Can you see it?
Yeah.
Yeah, you can see
Okay.
it. That's
So
what
we
I'm
did-
like kind of following here.
All right. So we didn't skin color.
Yep.
Right. And we didn't do any physical. So what's the last critical that you have to be careful of in primary assessment?
Circulation?
Nope. What's
Priority of the patient.
that? Right. So what's the priority? What do you think?
I'd say they're
High priority.
priority
Yeah.
one.
That's good. All right. So what are we going to update ALS with?
We're gonna update that we have a priority one patient with shallow breathing. Their skin is pale. What was it? Pale,
Warm and moist.
pale, warm, and moist.
Yep.
We have him on oxygen,
Okay.
and we will continue to assess.
Yeah, wheezing when you get close to him. Is he going into shock?
No, it doesn't look like it.
No? Okay.
Nope.
He's 9-year-old. He's coughing. Is there anything coming out?
Patient is coughing and with noticeable phlegm production. All right, so what else you want to do? What's the next couple boxes?
Oh, God damn it, that is so small. I can't see. Okay, so vitals.
Vitals. All right, so your patient's alert. His blood pressure is 122 on 80. His heart rate is 134 in regular. His respirations are 30 in shallow. His O2 is 94% on the O2 that you put him on. His GCS is 15, and because you are proactive, his blood sugar is 94.
Oh, the sugar. I always forget to say that.
Okay, so now what do you want to know? We did the skin already.
Mm-hmm. And the skin is pale. So.
Yep.
Oh no, but we're at the vitals now. Why am I going back up? So blood pressure.
Well, the skin's also the last part of the vitals.
Okay.
Yeah.
So it's pale and it's moist. Does he have a fever? Can we check on that?
He does have a fever. It's 101.
Okay.
His pulse rate was 134, correct?
Yep.
134 and regular. So
That's a little high, but not
Yeah, it's a little high, but it's not terrible.
Yeah.
Right? He's got a
Yeah.
fever. He's got some trouble breathing. He's coughing up phlegm. All right. So, right, he's got some sort of infection, right, of the lungs, right, because we're talking about bronchitis, right? So he's got bronchial infection.
And we can't even get a history because the parent is not present.
Yeah.
And the nurse just said that
would we be
right?
would we be able to get like an OPQRST?
There's no OPQRST.
All right.
The history is the patient apparently can't shake his cold. He's had a headache, sore throat, tired, shortness of breath, and a fever for the past couple days. He's been taking cough medicine. He had a donut around 8 o'clock this morning. He was in math class when he started feeling anxious and was unable to catch his breath. So he came to the nurse's office.
Okay, and at this point, we're already on the way, right?
Yeah, you guys decided you wanted to go, so.
Okay, so then we just notify the hospital with our reports, right?
Yeah.
And reassess every 5 minutes en route.
Good.
Mm-hmm.
All right, good job. So we'll do more of these when we get to labs. And you guys will be sick and tired of doing them by the time we get there. All right. Does anyone have any questions on anything?
Yeah, little question. So if we start, assessing a patient and we call ALS, and then, as we go along and we decide to move on, we realize that we don't really need ALS, we just cancel it or just
Yeah.
that's
Yep.
it.
You can just call and be like, hey, we're transporting, you can cancel ALS, or tell them if you really want them, tell them where you want them to meet you, and we'll try to find you somewhere. But yeah, for the most part,
Okay, that was it.
you can always, it's always better to ask and turn around than it is to not ask and need, you know what I mean? Or like, it's better to have and not need than need and not have, right?
Yeah, okay.
So, and yeah, you can always turn them around, they'll be happy.
All right, that was it.
And then they may not turn around. They may be like, well, I'm gonna go find out what this is because it sounds pretty bad and I might just want to poke my head in anyway. So, because I know a couple medics who are like that too. So, but Usually they won't pull you over on the side of the road. You can call it, you can cancel them, and if they're close by, they'll stop by anyway. I've done that a couple of times just to say hello. But otherwise, good job tonight. Good job. Hopefully I will see everybody on Monday, because now that we're all back, we can go to class.
Alright.
Otherwise, we're done for tonight. How is your citizen science thing going? How much longer is that?
I think till next week.
Next week?